Good afternoon, everyone. We're going to start our afternoon session. I hope every one of you had a nice break and you got nice lunch. Definitely the Lunch and Learn Roundtable was a success. Please consider signing one for tomorrow. It's really important. It's on GLP medications and our anesthesia management, definitely very important topic in our anesthesia practice. The afternoon will start with our cutting-edge topics, and the first presenter is Dr. Kevan Karkuti. He's going to present management of massive hemorrhage in the operating room. Dr. Karkuti was appointed chief of the Department of Anesthesia and Pain Management for Sinai Health University Healthwork Women's College Hospital in December 2018, that is in Canada. He has served as deputy chief at Toronto General Hospital since 2011 and has made an impactful contribution to the clinical research and education pillars of the department. He has held privileges at Mount Sinai Hospital since 2017 and has practiced in the three hospitals as well. Dr. Karkuti obtained his MD from the University of Toronto in 1990, followed by an anesthesia residency and a fellowship in anesthesia at St. Michael's Hospital. He also holds a Master of Clinical Epidemiology and Health Care Research and Health Administration from the University of Toronto and completed the Rotman School of Medicine Leadership Program. He is highly respected academician and professor and served as vice chair of innovation and research and chair of the promotions committee of the Department of Anesthesia. Dr. Karkuti is cross-appointed to the Institute of Health Policy, Management and Evaluation, as well as in the Departmental Division of Critical Care Medicine. Welcome.
Thank you very much for that wonderful introduction. It's an honor to be here, and I have two presentations. The first one's on management of massive hemorrhage in the operating room. My disclosures are here. Relevant disclosures, Octapharma, which makes various factor concentrates, and Werfen, who make relevant here would be point-of-care viscoelastic testing. So I'm going to start off by asking, what is massive hemorrhage? I mean, it's one of those things that's very easy for us to recognize, but we need to have kind of a standardized definition so we can implement management strategies, massive hemorrhage protocols, and so on. The problem is very hard to define, and there's various definitions listed here. And of all of these, depending on whether it's massive transfusion in the traditional sense or a dynamic massive transfusion, I think the one that really sticks to me is rapid bleeding rate is documented or observed. And as you can imagine, that's not very objective, it's very subjective. So the question is, can we come up with a more objective means? And I'll get back to this after a couple of other slides. I think visually, as I mentioned, it's easy to recognize what life-threatening and severe bleeding are. So this is a validation study of a visual score that categorizes that. We've used it actually for research in terms of classifying patients. So this is what they call life-threatening hemorrhage, bleeding that's occurring at the central site, venous or arterial, at a greater than 50 cc's per minute, which is 3 liters per hour kind of calculation. But I'm sure we've all had that picture, and it's not a comfortable situation to be in. So this is what they call severe. So this is one less category than that. So this is more peripheral, non-central venous or arterial, but still at 10 to 50 cc's per minute, which is substantial if you let it go on. So that's what they classify as that. When it comes to managing massive hemorrhage, I think there's two different phases with different objectives and management strategies. The first phase is the uncontrolled bleeding, which we are at times faced with in the operating room, but most of it is a trauma setting. But there are times in certain cases where you get uncontrolled bleeding that's relatively unexpected, which is not that much different with a trauma setting. And the objectives there are to optimize the surgical conditions so the surgeons can gain control and to keep the patient alive so that the sequelae of this problem are not then added to the patient's or impact the patient's outcomes. And then once the bleeding is controlled, the objectives are different. The objective is then to optimize hemostasis and then optimize any abnormalities in homeostasis that the patient may have suffered from the first phase of the bleeding. So to do that, for the first one, the management strategy is damage control resuscitation through a massive hemorrhage protocol. And the second one is goal-directed therapy in terms of controlled bleeding. And I'll give more information on both of these things. What is damage control resuscitation? Well, here is the four main components of DCR. This is an older paper, but basically not much has changed in terms of what we're supposed to be doing. One is permissive hypotension, minimization of crystalloids. It's important I'll get back to what permissive hypotension means because it's important in terms of our management strategy. Early control, that's kind of a common sense goal there. And then 1:1:1 product ratios. There's controversy there whether it should be 1:1:1, 1:1:2. My feeling is that it really doesn't matter what the product ratio is. The goal is to make sure that the objectives that I highlighted earlier are adhered to. So what is the overarching goal of damage control resuscitation? When I was in med school, we were taught that it was this, to avoid the lethal triad of acidosis, coagulopathy, and hypothermia. So this is a 1997 paper, so this is after my med school. Anyway, so since then, though, it's kind of changed. We've recognized the importance of hypocalcemia. So now it's the lethal diamond, hypothermia, coagulopathy, acidosis, and hypocalcemia, in fact, has a role in all those three, but by itself, it's also a big prognostic factor in terms of adverse outcomes. And the reason we thought we would avoid that was basically wasn't given much consideration in terms of what's driving the lethal triad or the lethal diamond. And this is a 1982 paper looking at the three things that we're trying to avoid, and it highlights tissue hypoxemia as playing an ancillary role into this issue. Over the years, we've come to recognize that tissue hypoxemia or shock is actually a big component of what happens in traumatic bleeding or in uncontrolled bleeding that may lead to harm. So it actually is probably the biggest contributor. When you look at trauma patients who go into shock and the ones who don't go into shock, there is a completely different phenotype. So you get trauma, shock, and hypoperfusion, which then gets you into the coagulopathy and then the lethal triad. But if you don't go into shock in a trauma patient, you actually could get into a thrombotic phenotype, so you don't get the coagulopathy that we're really worried about. So shock seems to be the major differentiator between the good outcomes in uncontrolled hemorrhage and the poor outcomes in uncontrolled hemorrhage. So the overarching goal of damage control resuscitation, as I mentioned, it's not the ratio of blood products and so on. It's get control of bleeding and avoid shock at all costs. So that permissive hypotension doesn't mean let the patient go into shock. It means a mean of systolic of 80 to 90. So kind of let them hang around loose. So the bleeding is kind of attenuated, but they're not in shock. Which goes back to the defining massive hemorrhage. If rapid bleeding is documented or observed, I think you can have a more objective thing. I think a good definition is bleeding that's likely to result in cellular shock without immediate transfusion support. Now, to do that, it's important to implement massive hemorrhage protocols. There's multiple benefits to having an MHP at the site, and in Canada, we've undertaken a major process to make sure every hospital, no matter how big or small, they do have a massive hemorrhage protocol in place. And the benefits, I've listed some of them there. They streamline rapid access to blood components, they decrease variability of treatment, and in fact, decrease wastage of blood products. They increase protocol compliance and facilitate interprofessional communication, which is really important in terms of making sure that everybody knows their responsibilities during a massively bleeding or uncontrolled hemorrhagic situation. In addition, they allow for tracking of metrics for quality improvement, but most importantly, they improve outcomes. This is a meta-analysis that was done a few years ago now, looking at the mortality outcomes when there was a massive transfusion protocol followed versus no massive transfusion or massive hemorrhage protocol followed. And as you can see there, the confidence interval is below 1. So this was a significant, almost 40% reduction in mortality when there was a massive transfusion protocol. So it's relatively small studies, some weaknesses, but the message is very clear that for uncontrolled bleeding, having a massive hemorrhage protocol that organizes our response is critically important. So this basically says what I said. I didn't talk about tranexamic acid because I'm focusing on different things, but obviously we don't want to forget tranexamic acid or the basics. And then my preference is to use 1:1:1 ratios, but no one should be criticized for using 1:1:2, for example. What you got to remember, though, is that every blood product we use, even if it's whole blood, is diluted by about a third. So even if you give whole blood in terms of uncontrolled bleeding, at some point that patient is going to become coagulopathic. So it's important to switch to a goal-directed therapy as soon as possible, which is the second part of the discussion in terms of once you have controlled bleeding, how do you go about managing the patient to make sure bleeding stops and they have the best outcome possible? So there are many guidelines and algorithms published for goal-directed bleeding management, but the message is that it's important to have an algorithm that's institutional, the institution is comfortable with, that it uses the resources you have, be it point-of-care assays or non-point-of-care or standard coagulation assays. I think there's increasing evidence that using point-of-care assays is preferable, but you can get most of the information you get from point-of-care assays if you do use standard assays in the right way. Here's some evidence. This hasn't been published yet, but looking at the effect of on mortality based on whether or not point-of-care guided algorithms were used or not used. And overall, again, you get about a 30% reduction in mortality if patients are managed with point-of-care assays. So I think there's increasing evidence that they do improve outcomes. This is our study that came out a few years ago now, almost a decade ago, where we looked at 12 hospitals and we switched them from their standard practice to a point-of-care guided coagulation management algorithm in cardiac surgery. The white boxes are, each row is a group of 2 hospitals. The white boxes are standard of care, and then after every month, randomly chosen 2 hospitals will switch to the black boxes, which is the intervention, which is the point-of-care algorithm. And what we found that overall, not only did we reduce transfusions by about 10% for red cells and platelets by about 20%, but we also had major bleeding reduction of about 20%. And major bleeding is one of the most important prognostic variables in terms of bleeding after cardiac surgery. We didn't find any difference in adverse outcomes, but the study wasn't really powered for that. So if you're going to do point-directed therapy, what are the targets we're looking at? I mean, coagulation is very complicated, and I'll come back to this in the next lecture. But essentially, it includes a lot of interrelated processes. The site of injury is where we want to really target in terms of adequate coagulation without causing thrombosis. And that site is dependent on not only the coagulation factors and those processes, but also the flow of the blood, the size of the vessel, and so on. So it's pretty complicated. Fortunately, though, there is only 3 targets that we really need to get at to have some impact on coagulation management. So one is fibrin levels, so treating hypofibrinogenemia, platelets, making sure we have adequate number of platelets that are well functioning, and then thrombin generation, which is dependent on enzymatic coagulation factor levels. Going on platelets, not much has happened in terms of our management or in terms of platelet treatment. We continue to, there's some controversy about what the threshold should be for giving a platelet transfusion. Guidelines say 50,000 for cardiac surgery, for example, 100,000 for neurosurgery. In practice, though, we pretty much use 100,000 for major bleeding in any type of surgery. So that really hasn't changed. What might change, though, in the coming next couple of years is what kind of platelets we give to our patients. Since the 60s, we've been using platelets that have been stored at room temperature. And the reason for that is here. It was discovered back then that if you cool down the platelets like we do for red cells, for example, or plasma, their survival after transfusion is substantially reduced. So I don't think I have laser. Anyway, on the right side here is our platelets that were stored at room temperature. And as you can see, they survive about 7 to 8 days, which is what your typical platelets last in your body anyway. So they last as long as normal platelets. Whereas on the left side, platelets that were only stored for 18 hours and cooled down for 18 hours, you can see their survivability drops to about 1 or 2 days. And because of that, we've been using room temperature platelets. But in bleeding patients, we really don't care how many days the platelets that we give last. We want the bleeding to stop, and then the patient's own platelets will take over eventually. So 1 or 2 days is quite long enough for that. So based on this kind of thinking, there is a major study that was recently finished recruitment in the States. We don't have the results yet, comparing cold stored with room temperature stored platelets. And beyond survivability. And the reason we're doing that now is because evidence suggests that cold stored platelets are actually better hemostatic agents than room temperature stored platelets. So these are all the differences that happen, but basically putting it very simply, when you cool down a unit of platelets, it becomes activated. So you're actually giving an activated hemostatic agent to patients. They stop bleeding faster. There's in vitro and in vivo experiments and human experiments showing that they function better as a hemostatic agent. So we'll hopefully have those results soon. We're doing a couple of studies in Canada looking at random donor platelets. Here they use apheresis platelets, so we'll have more evidence on this soon. As far as I know, that's really the only clinically relevant update in terms of platelet transfusions. Moving on to the second target, it's fibrinogen levels. The targets now are, for most cases, 1.5 to 2 grams per liter in bleeding patients. We do know that prophylactic therapy is not recommended. In fact, prophylactic therapy is not really recommended for any hemostatic agent for patients coming for surgery. Several studies looking at fibrinogen have found that to be true, and in fact, the ones who had prophylactic therapy had higher transfusion rates for some reason, which I can't explain. But anyway, no prophylactic therapy for hemostatic agents, including fibrinogen. The target, 1.5 to 2, is relatively new. Not that long ago, our targets were 0.8 to 1 gram per liter, and that was way too low based on evidence, observational studies that came out that showed that by the time you get to that stage, the horse has already left the barn. So 1.5 to 2 is the new target. The way I use that is if a patient's bleeding and they're below 1.5, I fix the fibrinogen first. If they're between 1.5 to 2, I fix the other stuff first and then get back to fibrinogen. So that's the way I translate that 1.5 to 2 grams per liter. We also know that plasma is not an effective therapy for increasing fibrinogen levels. As I mentioned, every unit that we have is diluted, and donors could have, before even dilution, their fibrinogen levels could be as low as 2 grams per liter in a normal person. So by the time you get to diluted, most fibrinogen units that you transfuse have less than 1.5 grams per liter. So we're never going to get over 2 grams per liter if you keep giving plasma. So plasma is not an option, which comes down to cryoprecipitate and fibrinogen concentrate. Now in the United States, you guys love cryoprecipitate, and there's now pathogen-reduced cryo. In Canada, we've now switched completely over to fibrinogen concentrate, and I think most of Europe is the same. But I'm going to present one of our studies that looked at the two and the reason why we switched over in Canada. This is an in vitro study looking at fibrinogen levels at baseline after dilution, which resembles what would happen in cardiopulmonary bypass or blood loss or dilution, and then fibrinogen levels with pathogen-reduced cryo, regular cryoprecipitate, or fibrinogen concentrate. And as you can see, their dose equivalence is about 4 grams of fibrinogen concentrate versus 10 units of cryo. But you get a much better response with fibrinogen concentrate because it's purified, standardized, concentrated, as opposed to cryoprecipitate that is variable, just like plasma. There's different amounts of fibrinogen in it. There's contaminants, and processing it changes its composition. Anyway, in vitro shows that fibrinogen concentrate, if your goal is to improve fibrinogen levels, fibrinogen concentrate is the superior agent according to studies like this. But what about clinically? So we published this study now about 5 years ago, and this was a non-inferiority study comparing fibrinogen concentrate to cryoprecipitate in cardiac surgery. It was a very pragmatic study. We got permission to get consent after the patients were included in this study, so essentially waiver of consent, because we were comparing two things that we argued were similar and didn't expose patients to risk. So if the patient was bleeding and the clinicians ordered one or the other product, at the time we had both available, the patient would be randomized by the blood bank to either 4 grams of fibrinogen or 10 units of cryo, and that's the one that the clinicians would use, the group that they were randomized to, and they could redose it as much as needed. This study included about 700 patients. The baseline characteristics were very similar. These are the surgical characteristics. Of note, about 70% were complex surgeries, so remember they had to be bleeding. So by the time they were bleeding, it's mostly complex surgeries. Different types of surgery, well balanced, including about 25% of patients who had CABG surgery. One of the concerns we kept hearing is what if, giving any hemostatic agent as opposed to the natural hemostatic agents, would cause thrombosis of the new grafts and so on. So these were well represented in the study. The one big difference in baseline characteristics was that patients who were critically ill before surgery, these are the ones who had cardiac arrest post-STEMI, for example, or aortic dissection. So really sick patients were 70% more common in the fibrinogen arm by chance. So the fibrinogen arm is sicker. And in fact, a priori, we had said that we would exclude these patients in subgroup analysis. This was a non-inferiority study, so the goal was to see the number of allogeneic units of red cells, platelets, and plasma in the fibrinogen arm relative to over the cryoprecipitate arm would be any different. So a ratio of 1 would be if the two were exactly the same. We allowed for a 20% margin of non-inferiority, so as long as the upper right side of the confidence interval was below 1.2, we would consider that non-inferior, and if it was below 1, it would be superior. Now, what stands out there that the non-inferiority is very clear based on the primary analysis set per protocol set and all the subgroups except for non-elective surgery. But if you look at the ones who excluded the critically ill patients, which is the ones that excluded them, but also the elective surgery population, which by definition didn't include those critically ill patients, fibrinogen concentrate was superior to the to cryoprecipitate in terms of allogeneic blood transfusion units. In terms of adverse events, no signals that it increased harm. In fact, numerically, there was reduced thromboembolic events in the fibrinogen arm, which is consistent with other studies that that compare the two products. We think that the contaminants in the microparticles in cryoprecipitate probably increase the risk of thromboembolic complications, and therefore giving a purified product is probably safer. In terms of cost effectiveness, these are Canadian data. This was basically the hospitals from Ontario. We took all the costs that the patients had in the hospital. The orange dots are the critically ill patients. As you can see, they're dispersed all over the place. So ignore the orange dots. The blue dots are the non-critically ill patients. Now, cost-effective, you can see on the x-axis is on the y-axis is change in costs. So the lower, the better. And on the x-axis is effectiveness. So ideally, you want to be in the right lower quadrant. It would be more effective and less costly. And in fact, 85% of the samples in this bootstrap 10,000 samples fall in that box. And on average, we had a $3,000 savings and saved 3.3 units by using fibrinogen concentrate, as long as you exclude the critically ill patients, in whom the relative impact of transfusions were relatively minor. And then the third component is coagulation factor replacement. As I mentioned, this is important for thrombin generation, and the goal is to enhance thrombin generation. We know in a significant number of patients after cardiac surgery, there is impaired thrombin generation. Unfortunately, there are no good clinical assays for us to determine who needs increasing their thrombin generation. We do have PT-INR, and it measures initiation of thrombin generation. And we do know that 95% of the thrombin happens after that point. And in the next lecture, that'll become clearer. We also have point-of-care assays. So clotting time, for example, in neurotime also is very analogous to INR, measures thrombin initiation. And then we have clot formation time and other dynamic factors in viscoelastic testing, which are kind of a catch-all for coagulopathy. The thrombin generation is part of it, but they're not very specific for that. So in reality, all we have is INR and clotting time to kind of give us a hint of who has coagulation factor, who needs replacement of coagulation factor. And when it comes down to treatment choices, we basically have frozen plasma or prothrombin complex concentrates. And when I talk about PCC, I talk about 4-factor PCCs. The evidence on 3-factor is not as good in terms of comparing it to plasma. And just like the last comparison, you worry about relative safety, effectiveness, and the costs. Now, in this study that was just published last month, what we compared, very similar to the fibrinogen concentrate study, we compared PCC with plasma for coagulopathic bleeding in cardiac surgery. As I mentioned, this was a 4-factor PCC. This was 12 hospitals that included 2 sites in Canada, in the US, Duke University and University of Oklahoma. The rest of the sites were in Canada. It was funded by Octapharma and also the Canadian Institutes of Health Research. The background why we did the study was that the primary therapy in most of the world is still frozen plasma for coagulopathic bleeding in cardiac surgery and most surgeries. And currently, about 30% of cardiac surgery patients still receive frozen plasma in our practice in North America. Preliminary evidence in vitro observation and our pilot studies suggested that PCCs may be a good substitute, but you've got to remember that PCCs only include 4 factors, 2, 7, 9, 10, as opposed to plasma that includes all the coagulation factors. So the question is that as effective as plasma despite the fact that they don't have all the factors? The other difference is they're 25 times more concentrated than plasma. So the question is, if you're giving a concentrated hemostatic agent, does it increase thromboembolic events? So those were the 2 questions that we needed answers to, which is why we did the study with the objective of comparing the efficacy and safety of PCC with plasma in bleeding cardiac surgery patients. As I mentioned, very similar to the study I presented, this was a very pragmatic study. Any adult patient in whom they were bleeding and there was evidence of coagulation factor deficiency would be randomized and included in the study. And to confirm that there was coagulation factor deficiency, we required that point-of-care INR be measured and an INR of more than 1.5, which means that coagulation factor levels are less than 50%. Would be required before patients would actually receive the intervention. In the US, we didn't get waiver of consent, so patients had to be consented before surgery. In Canada, we had waiver of consent, so this was similar to the last study I mentioned. So the patients would go to the operating room. If they were bleeding and clinicians ordered one or the other products, they would be randomized if they didn't have the exclusion criteria. And importantly, we excluded critically ill patients in this study. We learned from our experience from the last study. Patients would be randomized to the 2 arms. PCC dosage was designed to be about 25 units per kilo, and plasma dosage was designed to be about 10 to 15 cc's per kilo, depending on the weight that we get, low dose or high dose. Maximum of 2 doses, because you don't want to go over 50 units per kilo of PCC, because that's when the really concerns about imbalance of pro and anticoagulants come into play. So early in the course of bleeding, high INR, 25 units per kilo to start with, up to a maximum of 50 units. The primary outcome was effective hemostatic response, which was defined as whether the patients needed any hemostatic therapies or interventions from 1 hour after initiation of the treatment to 24 hours. And that 1 hour was there to allow clinicians to correct other abnormalities and to finish giving the plasma if they were randomized to the plasma arm. The power calculations are there. This was a non-inferiority study with a margin of 10% of non-inferiority. We calculated that we would need 410 patients to have enough power to show this primary difference in the primary outcome. We also looked at a whole bunch of secondary outcomes, including allogeneic transfusions, incidence of severe to massive bleeding, adverse events, and change in INR. Altogether, there were 528 patients randomized, of whom 108 were excluded after randomization, mostly because they ended up not needing the product. Either the bleeding stopped or INR wasn't high. 29 patients were excluded because we couldn't get consent on them. So overall, 213 patients in the PCC arm, 207 in the plasma arm, with very, very few major protocol deviations. So the per-protocol analysis was very similar. Baseline characteristics are on the left, very similar in terms of comorbidities, age, lab values, and then on the right you'll see the surgical characteristics. 70% again complex surgery, 40% had CABG in this case. Pump time was just under 3 hours, which again goes to the complexity of the cases. Everybody received 1 dose, and about 20% received a second dose of the intervention. So no more than 2 doses were allowed, as I mentioned earlier. And the average doses were within what we expected, about 25 units per kilo for PCC and 12 cc's per kilo for plasma. Not surprisingly, PCCs were administered much faster than plasma because it's 80 cc's versus a liter of volume in the 2 interventions. In terms of the primary outcome, so the hemostatic effectiveness was about 80% for PCC versus only about 60% for plasma, which means that PCC cut the risk of ineffectiveness by 50%. So it was twice as effective in terms of hemostatic effectiveness. And that was non-inferior and superior to plasma. This is the subgroup analysis and the primary analysis. Just like I showed you before, below 10% would be non-inferior, and below 0 would be superior. And here what's different is that almost every category, subgroup, and the main analysis showed superiority of PCC over plasma in terms of hemostatic effectiveness. In terms of secondary, these were really surprising. I didn't expect to see this much of a difference in favor of PCC. So severe to massive bleeding reduced by 50%. Total allogeneic transfusions reduced by 50% if you include all the plasma, and if you exclude the ones that were part of the treatment, still a 30% reduction in allogeneic blood transfusions and a better response of INR in the PCC arm. And adverse events, in terms of thromboembolic events, that were comparable, 8.5% versus 7.2%. But overall, you can see that almost everybody had some sort of an adverse event, which is not unusual in bleeding cardiac surgery patients. About 40% had serious adverse events, and I'm just going to focus on that. If you actually look at the numbers, 36% versus 47%. So there was a 25% reduction in serious adverse events in PCC compared to plasma. Acute kidney injury was reduced by 45%. Now, we don't think PCC has a renal protective strategy. What we think the pathophysiology or the mechanism is that you reduce severe to massive bleeding, and as I mentioned, that's a really important prognostic factor, and by that means you reduce serious adverse events, including AKI and respiratory complications. So to summarize, for uncontrolled bleeding, we need to have damage control resuscitation, early recognition, and implementation of massive hemorrhage protocols. We need to switch from ratio-based therapies to patient-specific therapies. And don't forget the basics. Don't forget tranexamic acid. And the primary goal is to avoid shock and the lethal diamond. Once we get to controlled bleeding, goal-directed bleeding management, and the key components are target the critical coagulation defects, so platelets, fibrinogen, thrombin generation, and coagulation factors. Implement point-of-care coagulation testing if possible, and I think there is increasing evidence that factor concentrates are superior, including in terms of their safety, logistics, and effectiveness. And as in the last slide, don't forget the basics, tranexamic acid if a patient's bleeding, and hypotension, severe anemia, acidosis, hypocalcemia, and hypothermia. So without addressing the basics, the secondaries really become not relevant. And with that, I'm going to stop. Thank you very much.